Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Welcome to the Deep Dive. We're here to really unpack complex research and give you the insights you need. Today, we're tackling something, incredibly important and, frankly, quite stubborn. It's that dangerous overlap between uncontrolled high blood pressure and chronic kidney disease.
It really is. And there's a potential new drug here, Baxdrostat, that might just offer a way to break that destructive cycle.
Let's set the stage first. Hypertension, high blood pressure. It's massive, right? A leading modifiable risk factor for death globally, cardiovascular events.
Absolutely. It's everywhere. And current treatments, while good for many, just aren't cutting it for some of the most vulnerable people.
And then you add kidney disease to the mix, chronic kidney disease, or CKD. We're talking, over 840 million people globally? It's staggering.
It is. And the link is incredibly strong. Maybe up to 90% of people with CKD also have hypertension.
That combination, it sounds lethal.
It often is. Uncontrolled high blood pressure isn't just, a comorbidity here. It actively drives the kidney disease forward. It makes it worse. Actually, something like 62% of deaths from CKD can be traced back to elevated systolic blood pressure. It's a huge driver.
So you have this large group of people already facing kidney issues, and their blood pressure just won't come down, even with the standard drugs.
Exactly. That's the core problem this research tackles. Many are already on things like ACE inhibitors or ARBs, angiotensin receptor blockers, often at the highest dose they can handle.
And it's still not enough.
Still not enough.
Yeah.
So the question becomes, what else is going on? Is there a specific, maybe hormonal pathway that these standard drugs aren't hitting effectively?
Which brings us to aldosterone.
Right. Aldosterone is really emerging as a key culprit here. It does a couple of nasty things. First, it tells the kidneys to hold on to sodium, which makes you retain water, and bam, blood pressure goes up.
Okay, that's the direct pressure effect.
Yeah. But it's more than that, especially long term. Aldosterone also promotes inflammation and, crucially, fibrosis. That's scarring in the kidney tissue. That scarring is what really progresses the kidney disease itself.
So it drives the pressure and physical damage, a double whammy.
Precisely.
Now, we've had drugs targeting this pathway before, right? The MRAs, mineralocorticoid receptor antagonists. What's different about this new approach with Baxdrostat?
It's a fundamentally different strategy. Older drugs, the MRAs, they basically block the receptor where aldosterone tries to deliver its message. Think of it like blocking the doorbell.
But the hormone itself is still floating around.
Exactly. Aldosterone is still being produced. Baxdrostat is different. It's what's called an aldosterone synthase inhibitor, or ASI, and it's designed to be very potent and highly selective.
Aldosterone synthase. So that's the enzyme that actually makes aldosterone.
You got it. Baxdrostat goes upstream. It shuts down the factory, inhibiting the enzyme so the hormone isn't synthesized in the first place. Less hormone, less signal, less damage.
A more direct approach.
A much more direct approach. And this Phase 2 trial, called FITE-TN, was designed to see if this new mechanism could really make a difference in this specific high-risk group of patients.
Okay, let's dive into the FITE-TN trial itself then. Phase 2, what was the core mission here?
The main goal was pretty straightforward. See if adding Baxdrostat to the treatment plan people were already on could effectively lower blood pressure and do it safely in these patients with both CKD and uncontrolled hypertension.
And the study design, you mentioned Phase 2.
Right. It was a Phase 2 randomized, double-blind, placebo-controlled study. That's a pretty rigorous design, especially the double-blind part. It means neither the patients nor the doctors knew who was getting the actual drug versus a placebo. Helps avoid bias.
Conducted across quite a few sites.
Yeah, 78 sites in the U.S., so decent spread.
The really critical part seems to be who was in this study. You said high-risk, treatment-resistant. What did that actually look like on paper?
Well, first off, everyone enrolled was already taking either an ACE inhibitor or an ARB. And not just taking it, but taking it at the maximum dose they could tolerate for at least 4 weeks before the study started.
So they were already failing the best standard care.
Essentially, yes. Their bodies were clearly resisting those foundational drugs.
You could see that resistance in their blood pressure numbers at the start.
Absolutely. Their average seated office systolic blood pressure at baseline was 151.2 millimeters of mercury. That's significantly high.
What were the entry criteria for pressure?
To get in, your systolic pressure had to be between 140 and 180. Or if you also had type 2 diabetes, the lower limit was slightly less strict, 130 to 180.
And diabetes was common in this group.
Very common. About 80% of the participants had type 2 diabetes, which, adds another layer of complexity and risk for both kidney and heart problems. Average age was around 66, too.
Okay, pressure was high. What about their kidney function? They had CKD, but not yet needing dialysis.
Correct. We measure kidney function using the estimated glomerular filtration rate, eGFR. It tells you how well the kidneys are filtering waste. The average eGFR in this group was 44.
44. And normal is above 90, with CKD stages kicking in below 60.
Right. So 44 puts them firmly in stage 3B CKD, moderate to severe disease. Significant loss of function had already happened.
And the marker for active damage, protein in the urine, the UACR.
The urine albumin creatinine ratio, UACR. Yeah, that tells you how much protein, specifically albumin, is leaking through the kidney's filters. It's a direct sign of damage. Their median UACR at baseline was 714 milligrams per gram.
Wow, 714. And the threshold to even get into the study was only 100.
Exactly. A median of 714 means most of them had macroalbuminuria, significant protein leakage. This is a really strong predictor of bad outcomes like progression to kidney failure or major heart events. This was definitely a high-risk group.
Okay, so high-risk failing standard therapy. The study ran for 26 weeks. How did they structure the treatment arms?
They used a 1-to-1-to-1 randomization. So roughly equal numbers of participants went into 3 groups. One group got a placebo, a sugar pill.
Okay.
Another group got a low dose of Baxdrostat. They started at 0.5 milligrams daily and could be increased or up-titrated to 1 milligram.
And the third group?
A high-dose Baxdrostat group. They started at 2 milligrams and could be titrated up to 4 milligrams.
And the main thing they were measuring at the end of 26 weeks was?
The primary endpoint was the change in that seated office systolic blood pressure from the beginning of the study to week 26. They compared the average change in the 2 Baxdrostat groups, combined the pooled group versus the change in the placebo group.
All right, let's get to those results then. After 26 weeks, adding Baxdrostat to existing therapy, did it work for these resistant patients?
It absolutely did. The results were statistically significant and clinically quite meaningful. The pooled Baxdrostat group, remember, low and high dose combined, had a placebo-corrected reduction in systolic blood pressure of 8.1 millimeters of mercury.
Minus 8.1 compared to placebo. For people already maxed out on other drugs, that feels substantial.
It is substantial. And importantly, this wasn't something that only showed up at the very end. They saw the blood pressure starting to drop as early as week 3, and that effect was maintained throughout the 26 weeks.
An early and sustained effect. That 8.1 drop, that could really shift someone's risk profile for things like stroke or heart attack down the line.
Definitely. Now, here's an interesting wrinkle they found, a kind of rehook for us. When they looked at the doses separately, and remember, the study wasn't really designed or powered to make definitive comparisons between the low and high dose.
Okay, caveat noted.
The low dose group actually had a numerically larger reduction. It was minus 9.0 millimeters of mercury compared to placebo.
Lower dose, slightly bigger drop?
Numerically, yes. The high dose group had a reduction of minus 7.2 millimeters of mercury. Again, not statistically proven to be different, but it raises a really interesting question.
Like, maybe you hit the maximum effect at a lower dose, and going higher doesn't add much benefit for pressure, but might increase side effects.
That's exactly the question it raises. It could be that once you inhibit aldosterone synthesis to a certain point, you get most of the blood pressure lowering effect tied to volume changes, and maybe pushing the dose higher doesn't squeeze out much more. That needs more investigation for sure.
It certainly has implications for finding the optimal dose later on. What about diastolic pressure?
Yeah, it went down too. The pooled Baxdrostat group saw a placebo-corrected drop of about 4.8 millimeters of mercury in diastolic pressure.
Okay, so it lowered both numbers. Did this translate into getting more patients to their actual blood pressure goal, say under 130 systolic?
Yes, and this is a key clinical outcome.
Yeah.
In the placebo group, only about 17% managed to get their systolic DP below 130 by week 26.
Not great.
Not great at all. But in the pooled Baxdrostat group, that number more than doubled to 36%. Getting over a third of these incredibly difficult-to-treat patients to goal is a significant achievement. It means fewer cardiovascular events down the road for those individuals.
That's a clear win on the blood pressure front.
Yeah.
You mentioned earlier that for CKD patients, maybe the even bigger story is about protecting the kidney itself, which leads us to that exploratory finding on albuminuria, the UACR.
Yes, this is where things get really exciting, I think, because it suggests the drug is doing more than just lowering pressure. The pooled Baxdrostat group showed a placebo-corrected percentage reduction in UACR of, wait for it, 55.2%.
55.2% reduction in protein leakage. That sounds massive.
It is massive. This isn't a trivial change. It's a profound reduction in a key marker of ongoing kidney damage.
Why is a UACR reduction of that size considered so important? What does it tell us?
Well, numerous large studies, meta-analyses, have shown that reducing UACR is a validated surrogate endpoint. Basically, big drops in UACR strongly predict a lower risk of the really bad clinical kidney outcomes later on, things like needing dialysis, transplantation, or a sharp decline in kidney function.
So a 55% drop today suggests a much lower chance of kidney failure down the line.
That's the strong implication. And the fact that you see this huge UACR reduction alongside the significant but perhaps not earth-shattering 8.1 millimeter drop in blood pressure, it really points toward Baxdrostat working through mechanisms beyond just pressure lowering.
Like directly tackling that aldosterone-driven inflammation and fibrosis in the kidney.
Exactly. It suggests it's hitting those blood pressure-independent pathways of damage. This really supports the whole rationale behind developing an aldosterone synthase inhibitor in the first place. It seems to be doing what it was designed to do at the tissue level.
Okay, powerful efficacy, especially on that kidney damage marker. But we have to talk safety. With drugs that block aldosterone, the immediate concern is always potassium, right? Hyperkalemia.
Yep, that's the known trade-off. Aldosterone normally helps your kidneys get rid of potassium. So if you inhibit aldosterone synthesis or block its action, potassium levels are likely to rise. It was definitely the most anticipated and indeed the most common adverse event in this trial.
The numbers reported seem quite high at first glance. Hyperkalemia occurred in 41% of the pooled Baxdrostat group. That's compared to only 5% in the placebo group. How do we interpret that? 41% sounds like a lot.
It does sound high, and it absolutely requires careful attention. The investigators provided important context, though. They noted that most of these events were mild or moderate in severity, and often they were transient.
Meaning the level went up on one test, but might have been normal on a follow-up test without intervention.
Correct, or easily managed with standard protocols. However, we can't minimize it. The data does show that 11% of those on Baxdrostat had at least one potassium reading above 6.0 milliequivalents per liter, which is definitely clinically significant hyperkalemia. 0% of the placebo group hit that level.
And that risk led to some people having to stop taking the drug.
Yes. 9 participants, which is about 7% of the Baxdrostat group, had to discontinue the treatment specifically due to hyperkalemia. So while often manageable, it's a real risk that requires close monitoring, especially when starting the therapy. This is the main safety hurdle to overcome for wider use.
Okay, potassium is the big one. What about effects on the kidney function itself, the eGFR? Sometimes starting drugs like ACE inhibitors causes an initial dip. Did they see that here?
They did see an initial small reduction in eGFR, which is quite common and often expected with drugs that affect kidney hemodynamics, the blood flow and pressure inside the kidney's filters. It's often considered a sign the drug is working, reducing damaging hyperfiltration pressure.
But did it stabilize? What was the net effect at 26 weeks?
It did stabilize. At the end of the 26 weeks, the change in eGFR in the pooled Baxdrostat group was quite modest, only about minus 2.3 milliliters per minute compared to placebo.
So a small, acceptable drop.
Generally considered acceptable, yes. They also saw more participants reporting increased blood creatinine, another kidney marker in the Baxdrostat group, about 20% versus 8%. But crucially, all of these were classified as non-serious events. Nobody needed hospitalization for kidney issues related to the drug. It suggests the initial kidney effects were manageable.
Now, let's talk about a major potential pitfall for this class of drug selectivity. You mentioned Baxdrostat is an aldosterone synthase inhibitor. The enzyme that makes aldosterone looks very similar to the enzyme that makes cortisol, right? 11-beta-hydroxylase.
Extremely similar. And that's been the Achilles heel for developing ASIs for decades. If you accidentally block cortisol production too much, you cause adrenal insufficiency, which is dangerous.
So the key is designing a molecule that hits aldosterone synthase but leaves cortisol synthesis alone. Did Baxdrostat achieve that selectivity?
This seems to be a major success story for this compound. It was specifically engineered for high selectivity, reportedly a 100-to-1 preference for aldosterone synthase over the cortisol enzyme.
And did that translate into safety in the trial?
It appears so. The crucial finding here is that there were 0 reported adverse events related to adrenal insufficiency during the entire FITE-TN trial. No signs of cortisol deficiency. That's a huge validation of the drug's selective design and a critical safety milestone.
That's really reassuring. So Pulling it all together, significant blood pressure lowering in tough-to-treat patients, plus this really impressive 55% reduction in the kidney damage marker, UACR. What are the broader implications here? How might this change things?
Well, it strongly suggests we're moving beyond just general blood pressure targets. We're looking at therapies that can precisely target the specific hormonal pathways, like aldosterone, that actively drive the fibrosis and inflammation underlying kidney disease progression, pathways that maybe aren't fully addressed by just ACEs or ARBs alone.
It feels more like tackling the root cause.
In a way, yes. And I think Dr. Jordana Cohen, an external expert who commented on this, put it well. She highlighted that patients with CKD, especially more advanced CKD like in this trial, have often been excluded from major drug studies in the past because they're seen as too complex or high risk.
Right, making it hard to know if new drugs are safe or effective for them.
Exactly. So the fact that Baxdrostat showed both safety, particularly that selectivity and manageable kidney effects, and this level of efficacy in this specific challenging population is really encouraging. Dr. Cohen called this class of drugs a potential game changer.
The game changer. Looking at that 55% UACR reduction again, how does that compare roughly to other known kidney protective drugs, like, say, finerenone or SGLT2 inhibitors?
It compares very favorably, though we always have to be cautious comparing across different trials with different populations. Finerenone, which is a nonsteroidal MRA, showed UACR reductions in the ballpark of 30 to 38% in its major trials. Older MRAs like eplerenone may be up to 33%. SGLT2 inhibitors also show significant UACR reduction, often around 30–40%.
So 55% really stands out.
It definitely stands out as a particularly large reduction reported in this Phase 2 setting. It places Baxdrostat potentially among the most potent agents for reducing albuminuria discovered so far.
But we keep coming back to that hyperkalemia risk. The 41% incidence, even if mostly mild, that's a hurdle for everyday clinical practice. How do researchers plan to deal with that? What's the strategy?
The clear path forward, and what's being actively tested now, is combination therapy. The idea isn't necessarily to use Baxdrostat alone in everyone, but to partner it intelligently.
Partner it with what?
The most promising combination currently under investigation is Baxdrostat plus an SGLT2 inhibitor.
The SGLT2 inhibitors. Those drugs initially for diabetes that turned out to have amazing heart and kidney benefits on their own. Why would combining them with Baxdrostat potentially solve the potassium problem?
It's based on their complementary mechanisms and known effects. SGLT2 inhibitors work primarily in the proximal tubule of the kidney, increasing glucose and sodium excretion. But studies have shown they also tend to have a modest potassium-lowering effect, or at least help stabilize potassium levels. They seem to mitigate the risk of hyperkalemia.
Interesting. So you get the powerful aldosterone blockade and antifibrotic effects from Baxdrostat,
Which might come with that potassium risk.
and you add the SGLT2 inhibitor, which provides its own cardio-renal benefits through different mechanisms and potentially counteracts or buffers the rise in potassium caused by Baxdrostat.
That's the hypothesis. It's aiming for synergy, maximizing the kidney and heart protection from both drug classes while creating a better overall safety profile, specifically making the hyperkalemia more manageable for routine clinical use.
A potentially very elegant solution.
If it works out in the large trials, yes. That combination strategy is really the cornerstone of the ongoing Phase 3 program.
Okay, let's touch on the limitations of this specific FITE-TN study. Phase 2 trials are usually about proof of concept, not definitive answers. What were the acknowledged weaknesses here?
Well, the most obvious one is the size. With just under 200 participants randomized, it's relatively small for making broad conclusions. This limits the statistical power.
Which relates back to that dose comparison issue we discussed.
Exactly. That finding where the low dose looked numerically better could just be random chance in a small group. You need much larger numbers, like in Phase 3, to really tease out dose-response relationships reliably.
Any other key limitations?
Another one was the type of blood pressure measurement used. They focused on office blood pressure readings taken in the clinic setting.
Not 24-hour monitoring?
No, they didn't use ambulatory blood pressure monitoring or ABPM. ATPM gives you a much better picture of blood pressure control throughout the day and night, outside the potentially stressful clinic environment. It's generally considered a better predictor of risk. Future studies will need that ABPM data.
And wasn't there something about the study protocol itself changing midstream?
Yes, that's a procedural point. The specific rules for how doctors should adjust the dose based on potassium and sodium levels were modified partway through the trial.
Why does that matter?
It just means they didn't use one single, fully optimized conservative management algorithm for the entire study duration. It slightly limits how well we can assess the drug's performance under what would eventually be the final, standardized guidelines for managing those electrolytes in clinical practice.
Okay, understandable limitations for a phase 2 study, but clearly the results were strong enough to move forward. What does that future road look like? You mentioned phase 3 trials are underway.
Yes, there's a major phase 3 program ongoing, focusing largely on that combination therapy with SGLT2 inhibitors. There are several large trials, each designed to answer critical questions.
Can you give us a sense of what they're looking at?
Sure. One major trial, you can find it registered as NCT06268873, is specifically looking at the combination of Baxdrostat, likely with dapagliflozin and SGLT2I, and its effect on CKD progression. They'll measure the slope of eGFR decline over time. That's a hard endpoint for kidney protection. Does it actually slow the disease down long-term?
Okay. Direct impact on kidney function decline. What else?
Another crucial trial, NCT06742723, is looking at major clinical events. This is the big one for regulatory approval. It will assess if the combination therapy reduces the rate of major cardiovascular events like heart attack, stroke, and major kidney events like progression to kidney failure or significant GFR loss.
So moving from markers like UACR to actual patient outcomes.
Exactly. Survival, hospitalizations, dialysis, the things that matter most to patients. And there's a third large trial, NCT06677060, focusing specifically on cardiovascular mortality and heart failure.
Why a separate focus on heart failure?
Because the link between kidney disease and heart failure is incredibly strong. If this combination can reduce the risk of dying from cardiovascular causes and reduce the development of new heart failure, even beyond its effects on CKD progression, that demonstrates a really broad, powerful cardio-renal protective benefit.
So these 3 trials together aim to provide definitive evidence on slowing kidney disease, preventing major heart and kidney events, and reducing mortality and heart failure.
That's the goal. It's a comprehensive program designed to establish this combination, if successful, as a new standard of care for this very high-risk population.
So let's wrap up this deep dive. The FITE-TN trial, despite being phase 2, delivered some really compelling findings for Baxdrostat.
It really did. You have significant blood pressure lowering in patients who weren't responding well to standard therapy. That's a clinical need right there.
And then arguably the headline finding, that massive 55% reduction in albuminuria, suggesting potent direct kidney protection.
Yes, the UACR reduction points towards a mechanism that goes beyond just pressure, hitting the underlying aldosterone-driven damage pathways.
It feels like a shift, doesn't it? From broadly managing symptoms like high blood pressure towards targeting the specific molecular engines driving the disease itself.
I think that's a great way to put it. For patients stuck in that cycle of worsening kidney function and high cardiovascular risk, therapies like this offer hope, not just for better numbers, but for potentially slowing or even halting the disease process.
So here's a thought to leave you with. That 55% reduction in the UACR. Maybe it signals a future where treating complex conditions like CKD isn't just about controlling the symptoms we can easily measure, like blood pressure. Maybe it's about precisely identifying and disabling the specific hormonal culprits, like aldosterone, that are causing the damage at the tissue level. Are we moving from managing decline to actively preventing failure?
That's certainly the promise. The big hurdle, as we've discussed, is proving that the combination approach, likely with SGLT2 inhibitors, can effectively manage the hyperkalemia risk while delivering on that powerful dual efficacy for both the heart and the kidney in large long-term studies. If those phase 3 trials succeed, it truly could redefine cardiorenal disease management for millions worldwide.
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.